Everybody, I want to thank you for joining us for tonight's webinar with Dr. Mark Houston. Tonight's webinar is going to be a preview of Module 16A in the metabolic and cardiovascular medicine. Module 16A is going to be held in Las Vegas at the Aria Resort and Casino on February 28th through March 2nd, 2013, next month. If you have any questions about this webinar, that module, or anything else, please give us a call, 561-997-0112, a4m.com, or send us an email, info@a4m.com. Dr. Mark Houston is an associate clinical professor of medicine at Vanderbilt University's School of Medicine, director of Hypertension Institute and Vascular Biology, and medical director of the Division of Human Nutrition at St. Thomas Medical Group at the St. Thomas Hospital in Nashville, Tennessee. Dr. Houston, the floor is yours. Thank you.
Good. Thanks so much, Daniel, and thank you all for joining us tonight. The topic this evening is the precipice of a revolution in the treatment of cardiovascular disease. Hopefully you all have a handout. If you don't, Daniel, as he said, we'll get that to you tomorrow. This is just a tip of the iceberg of what's happening in cardiovascular medicine in 2013 and for the next several years. For those of you that really would like to delve into this in more detail, as Daniel mentioned, I direct the Advanced Cardiovascular module for A4M. And 16A is coming up, as he said, in Las Vegas in February. And then we have not only 16A, but also 16B, C, and D. So this is a 96-hour advanced CV cardiovascular certification course for any of you that might want to get more information. I hope to whet your appetite tonight with what we're going to talk about related to CVD. So let's get started on some very broad concepts first, and then we'll dive into some of the nuances of clinical cardiovascular disease. The format tonight will be approximately 15 to 20 minutes of me talking to you to give you the guidance on what we're doing. And then I'm going to open this up to Q&A to the audience. And you can respond in one of two ways. You can go on the website and post a question, or Daniel will be able, hopefully, to open up the lines to verbal questions as well. And I did receive a few emails from some of you already with some questions, which I'll address when we get to the Q&A session.
Correct. Yes, we'll address all the questions at the end of the webinar. If you want to write those questions in the question box, so we have them written down, we'll be able to answer them today or tomorrow if necessary. So, sorry. Thank you.
Okay. Thanks, Daniel. The big concept in cardiovascular disease is that we have reached a limit with present evaluations of our risk factors to further reduce cardiovascular disease in this country. CVD and myocardial infarction are the #1 cause of death in the United States, stroke being #3. So if you lump myocardial infarction, coronary heart disease, and stroke together, they are outperforming any other cause of death related to any other cause, including cancer. So this is what we really have to establish as our goal in reducing morbidity and mortality by taking a totally new approach in CVD. So most of you were taught that there were 5 risk factors for coronary heart disease: hypertension, dyslipidemia, diabetes mellitus, obesity, and smoking. The problem is, if you address those 5 risk factors in the traditional way that we've been taught, you still miss 50% of the causes of coronary heart disease. So if a patient shows up in the emergency room in the hospital with an acute MI, and you measure those risk factors, 50% of the time they don't have them as presently defined. So one of my goals tonight is to redefine what those top 5 risk factors are, but also go to the next step, which is for you to realize there's not just 5, there's actually over 400. And we won't be talking about the 400 risk factors tonight because that's part of what we do in the Advanced CV course for Module 16. But I want to give you a broad scope of what we're talking about and how those risk factors affect your blood vessel. So here's the most important thing I'm going to say to you tonight, and it is a new concept in how to not only evaluate patients and look at non-diagnostic or non-invasive testing, but also what you do with your therapy. And that is this: there's an infinite number of insults to the artery, but there's only 3 finite responses. So if we take the 400 plus risk factors or insults or environmental influences that attack the endothelium and the artery says, you know, I don't care what you're throwing at me, I'm only going to respond in one of 3 ways. So the 3 mechanisms by which the artery responds to everything is inflammation, oxidative stress, and vascular immune dysfunction. So if you understand those 3 processes and you know how to measure them clinically with laboratory tests, either blood test, urine test, or non-invasive cardiovascular test, you then turn upside down the way you manage and approach cardiovascular disease. So instead of just saying, well, I'm just going to measure their blood pressure and their lipids, you're now going to try to measure one of the 3 or all 3 of the finite consequences and determine if they're inflamed, okay, what is it that causes the inflammation of the artery? Backtrack. You know, is it their hypertension? Is it their dyslipidemia? Is it their heavy metals? Is it their homocysteine? Is it their oxidized LDL? Is it whatever? Then you say, okay, the patient has oxidative stress. What's causing that? And you backtrack to those causes. Same thing with autoimmune disease in the arteries. So by identifying the finite pathophysiology, you basically start to understand why the blood vessels has responded the way it has, and then try to find the etiology. And what I want to teach you is how you clinically measure those things, and then how you backtrack up to the cause. Now, the traditional approach, for example, let's say if you had a patient come in and they were hypertensive, and you would look at everything and you say, well, your blood pressure is the only problem I can find, so I'm not going to worry about anything else. Let's get your blood pressure controlled. So you do that, either with lifestyle changes or with drugs. Well, that patient, if evaluated that way without testing appropriately, not only the top 5, but the other major risk factors that are out there, still is going to have a very high risk for coronary heart disease because you've missed a lot of things. So within each of the traditional risk factors, there are some very serious mistakes that are being made right now in the definition of the risk factor and how you evaluate it. So what I want to do now is take the top 5 risk factors, tell you what we're presently doing, and then what we're presently doing wrong, and what you need to correct it. So hypertension. How do you usually do your hypertension workup as far as evaluating, is a patient hypertensive? Well, you do it a lot of ways. One is you give them a cuff, and they take it home and do home blood pressure measurements. 2, you measure it in your office. Or 3, if you can afford to get the machinery and the insurance pays you, you get a 24-hour ambulatory blood pressure monitor. So if you do any of those 3 things, you have to ask yourself the question, which of those 3 is most likely to give me a valid evaluation of what's going on with this patient's blood pressure? Well, if you measure office pressures or home blood pressures, you will not get the evidence you need to make an appropriate diagnosis or an appropriate treatment of the patient for hypertension. Because the only test that picks up the things you need to know about is a 24-hour blood pressure monitor with some sort of test that measures the arterial function. By that I mean measuring endothelial function and arterial elasticity. Because the blood pressure itself is not the problem. It is what the blood pressure is doing to the artery. And which comes first? Does the blood pressure come first, or does the arterial disease come first? And it's probably a little bit of both. But those 2 feed into each other bidirectionally. So, for example, measuring an office blood pressure or home blood pressure, you get a number. It doesn't tell you anything about the fluctuations during the day. It doesn't tell you anything about the blood pressure load. That is, if you average the readings over 24 hours, what are they? It doesn't tell you anything about circadian rhythm. Does the blood pressure go down at a certain time, or does it go up real fast in the morning, and how quickly does it go up? That's called the surge. And it doesn't tell you about another important factor called dipping, which is the decrease in blood pressure that occurs when you go to sleep. And there's people that don't dip. In other words, their pressure doesn't drop below the cutoff point, which is about a 10% decrease. So if you drop too much, that's bad. If you don't drop enough, that's bad. You have to dip just the right amount. So the entire diagnosis of hypertension has to be based on new criteria, which is a 24-hour blood pressure monitor. And you couple that with these non-invasive tests, for example, like an Endopat to measure endothelial dysfunction, and also with another machine we have called a pulse wave, which measures the elasticity of the arteries. And once you see that, you begin to determine how those two interrelate and what you need to do. Now, let me give you one little clinical pearl so you understand how important this is. Let's suppose you did a 24-hour blood pressure monitor, and the average blood pressure for 24 hours was very good, and you're real happy with it, but you look at the details on your report, it says patient is a non-dipper, which means that their blood pressure is not dropping that 10% at night. That patient's at higher risk now to have a stroke or heart attack, unless you can turn them from a non-dipper to a dipper. So what nutraceutical do you know about that would change a patient from a non-dipping to a dipping pattern? Turns out it's melatonin, and it works very easily. Sometimes only 3 milligrams a night of melatonin will convert you, and that can actually save people's lives because it changes them to a dipping patient. There's also drugs that do it, particularly ACE inhibitors and ARBs. So that's sort of, in a nutshell, some things we're doing with blood pressure. Now, the next one, which is really not being addressed appropriately, is dyslipidemia. All the present lipid profiles that you guys have heard about are obsolete. You've got to do an advanced lipid profile. And the advanced lipid profile is done by a lot of companies. It's done by SpectraCell, LipoScience, Berkeley Heart Labs, and Athertech. But the basic idea is you need to measure particle number and particle size. So this includes LDL, HDL, and VLDL. So the advanced profiles will tell you if they have an increased number of LDL particles, and that is what drives risk for dyslipidemic-induced vascular disease. The more LDL particles you have, and the smaller they are, the more likely you are to get atherosclerosis. Many of you have heard me use the tennis net analogy. If you think of your LDL particle as a tennis ball or a golf ball, and you use the net as the endothelium, you cannot hit a tennis ball through the net, but you can easily drive a golf ball through there. So the small, dense, type B LDL as a golf ball goes through the net to the other side, deposits in the subendothelial layer, and starts to cause foam cells and atherosclerosis. The tennis ball is the type A. Larger LDL doesn't go through, so it stays on the outside, gets recirculated to the liver, and it's finally excreted. So if you know that dense LDL is bad and you got a lot of them, there's more of those going across. So high particles and dense, two major risk factors for driving atherosclerotic disease. So once you identify that, the next part is what's going on with the reverse cholesterol transport. What's the cleanup crew going to do? That's where your HDL comes in. So this is like the big garbage truck, little garbage truck, functional or dysfunctional HDL. HDL takes the LDL out of the artery to the liver and excretes it. So if you have the wrong kind of HDL, you can't clean up the mess. So you want big HDL, and it has to work. So the analogy here is you want a big garbage truck that's got a good engine and 4 wheels. It can go pick up the LDL garbage and get it out of there, take it somewhere, dump it, and get rid of it. So there's HDL particle size that's big, but the problem is just because it's big doesn't always mean it works. And one of the things we're learning is HDL can be dysfunctional, which means it is big, but it doesn't do what it's supposed to do. And there are ways we measure for those things. One of the key things that you should remember, another clinical pearl, is the most common reason for a dysfunctional HDL is inflammation and oxidative stress, which, by the way, are two of the major things that cause vascular disease to begin with. That's one of the finite responses. So if you see, for example, a patient, particularly females who have HDLs over 85, at least half, if not more, of those females have dysfunctional HDL. So in the old days, a high HDL was thought to be protective and good. Turns out that a lot of the people who have high HDL, it's dysfunctional, and it's had to go up to try to maintain its reverse cholesterol transport because it's not working very well. So that's a red flag. Female, high HDL, family history of heart disease, or some other issues with the cardiovascular system, think of dysfunctional HDL. Can you measure that? Not really, but you can measure parameters or markers for dysfunction. So I told you what causes it, which is inflammation and oxidative stress. So the two things you would want to measure is C-reactive protein and myeloperoxidase, or MPO. MPO is an enzyme that makes the apolipoprotein A, which is part of HDL, dysfunctional. So those are easy to get now in clinical labs, and they give you an idea of their risk. The third risk factor is dysglycemia. And as most of you know, if you've attended any of the modules, if you have a fasting blood sugar over about 80 or 85, then you're at risk for having insulin resistance and type 2 diabetes later. And the risk is very projected, and it goes up about 1 point of risk for coronary heart disease, so 1% increase in coronary heart disease or MI for every 1 milligram percent increase in your fasting blood sugar starting at 80. So, for example, if you have a fasting blood sugar of 100, which is right at the upper limits by most labs, that patient from 80 to 100 is a 20-point difference. That means you have a 20% increase in the risk for myocardial infarction, even within the, quote, normal ranges, which are really not normal, so they have to be redefined. And you also have to remember that fasting blood sugar should be mixed with your 2-hour postprandial or 2-hour glucose tolerance. So you can have, either of those two or both of them as abnormalities. So when you do a 2-hour glucose tolerance test, most of the labs would say a normal level at 2 hours would be less than 140. That's not correct. It actually should be less than 110. So let's say you had, quote, the normal level by the lab at 140, but it should be 110. So that's a 30-point difference. Well, that 30-point difference now translates in a doubling of that difference. So now it's a 30-point difference, but it's a 60% increase in risk for myocardial infarction. The other two top risk factors, obesity and smoking, are pretty straightforward. You lose your visceral fat, get rid of the adipokines, and all those inflammatory and other negative cytokines go away. Smoking, obviously is bad for everything related to oxidative stress and inflammation. So those are the top 5, but we, as I said, we have defined them incorrectly, so no one's treating them appropriately. Therefore, we're not even treating the top 5 right. And then you add to that the other 395 that a lot of people don't even measure, like homocysteine or C-reactive protein, oxidized LDL. I mean, the list is enormous. And in the book that I just wrote this year, which is what your doctor may not tell you about heart disease, we go into all 395 plus risk factors plus the top 5 and these concepts on inflammation, oxidative stress, and immune dysfunction of the arteries. And then we go into all the different treatments with nutrition and nutraceuticals and drugs and use an integrative approach. So what you want to do now in your approach to cardiovascular disease is to identify the 3 finite responses, backtrack to find the etiology, and remember it's a lot more than we used to think, define the top 5 correctly, learn about the laboratory tests that you can do in blood to identify those risk factors like C-reactive protein, myeloperoxidase, oxidative stress markers, and immune dysfunction markers. You measure those, find the cause, get them treated, track it back from the bottom up, not so much from the top down. And then once you have that, you start looking at non-invasive measurements of the endothelium, because that's really where the action is. If the endothelium is dysfunctional, then you're going to have oxidative stress, inflammation, increased clotting and thrombosis, and a lot of other problems in the artery. So you've got to get the endothelial dysfunction corrected, and that usually requires a pretty aggressive approach with nutrition, nutraceutical supplements, and usually drugs in an integrative approach. There's a lot of new tests out there that we can do that measure endothelial dysfunction. There's one called the Endopat. There's another that measures arterial elasticity, which is a pulse wave analysis. There's a third one that measures endothelial function called digital thermography. And then we have a lot of other non-invasive tests that measure the role of the sympathetic and parasympathetic nervous system. How does that respond to all these risk factors? Heart rate variability, heart rate recovery time, and then the new computerized electrocardiogram, which is very accurate in predicting coronary heart disease risk. So the way we are presently diagnosing and treating cardiovascular disease in this country and across the world is really obsolete, and we've got to go back now and look at the new concepts of what are the finite responses, what are all the risk factors out there, and then start trying to get to better treatments with not just drugs, but preventing the disease with the appropriate nutritional concepts. And there's a lot of good science out there now showing that a lot of nutraceuticals are very effective in not only reducing coronary heart disease, but actually treating it if you have it. Again, just to give you a few clinical pearls, for example, we can now reverse coronary heart disease plaque by using a combination of omega-3 fatty acids, aged garlic, and vitamin K2, MK7. We can actually prevent stent restenosis and graft stenosis after bypass graft with the high doses of curcumin, which is a turmeric. So these studies are available in the literature. They're well done. They're double-blind, placebo-controlled. But unfortunately, a lot of the traditional cardiologists either don't know about them or not using them, but stick to a lot of the old methodologies. And unless we change that, we're never going to be able to get past this 50% coronary heart disease gap, which is really the issue. That means half the people are being treated still end up having a heart attack, despite the fact that all the risk factors look really good on paper. Now, I know that's a huge amount of information. I've really just skimmed the surface here to get you interested. And what I'm going to do is I'm going to stop the didactic part here, and we're going to open this up for Q&A. But before I do that, I just want to respond to one of our attendees who emailed a few questions earlier. This is from Zelda Johnson. And Zelda, if you're on the line, if I don't answer your questions, please come on and help me to answer them better. So the first question was, do I have any experience or understanding on how to combine the treating of hypertension care with homeopathy? I think there is some great concepts here, which is the hormetic concept is a very good one, which is a little bit of something for a long period of time that doesn't kill you can actually create a defense mechanism in your cells through increasing oxidative defense or detoxification pathways. So although I don't have experience with homeopathic methods, I understand what you're asking, and I think that there are studies that need to be done. Fortunately, there are very few studies related to blood pressure and homeopathy that are published in the literature. But I think that one of the things that we're learning, which is directly related to your question, is that some of the antioxidants that we use to treat blood pressure actually work through a homeopathic mechanism, which is to increase oxidative defense, and that does reduce oxidative stress. Her second question was, what are my thoughts about quote, cocktail therapies with different drugs like beta blockers, calcium blockers, and ACE inhibitors. And most all of the pharmacologic treatments for hypertension do work well together, with a couple of exceptions. You never use two beta blockers together, and you don't typically use an ACE inhibitor with an ARB anymore, based on some recent studies like the on target trial. But most other combinations, ACEs and ARBs with CCBs work, beta blockers with any of the other agents, certainly diuretics of the best type, which is drugs like indapamide. You want to stay away from hydrochlorothiazide and chlorothalidone because those drugs tend to increase blood sugar and cause dyslipidemic profiles. And her third and final question was, African American populations suffer from hypertension perhaps more than other ethnicities. What treatments are best for them? Very true. African Americans tend to have more complications at similar blood pressure levels, but if you ask yourself the question, why is that? It's because most of the African American population do not dip at night, and therefore their pressures during the evening hours are higher, so their set points have more arterial damage in the nocturnal hours, and therefore they have more target organ damage. The best pharmacologic treatment for African Americans with hypertension are calcium channel blockers. They actually work better than diuretics, and they don't have all the downsides of metabolic effects either. So
Great.
those were her three questions. So let me open up the Q&A session now for either verbal or, Dan, if you want to read some of the questions off, whatever you need to do is great.
Sure. The first question is going to be from Linda. Linda, if you're ready, please go ahead and answer your ask your question. Linda, are you there? Nope. Okay. I'll read it for her. She writes, with the new krill oil on the market with DHA and EPA, how much fish oil do we need to take for best cardiovascular protection?
Great question. If you're doing prevention, you can get by sometimes with small doses of like 1 to 1.5 grams per day of DHA and EPA. But if you're treating a patient who already has hypertension or has dyslipidemia or diabetes or insulin resistance, you want to go to higher doses, typically 3 to 5 grams per day, using a balanced EPA, DHA, GLA, and use use gamma delta tocopherol with it to prevent the oxidation that occurs in the cell membranes.
Perfect. Well, the next question comes from Wallace. Wallace, if you're available, please go ahead and ask your question. You've been unmuted. Turn down your speaker, please. You there, Wallace? Wallace, are you there? You can ask your question on the webinar. Oh, okay. Well, Wallace's question was on info. He wants some info on the LPPLA2 test. The LPPLA2 test.
Okay. LPPLA2 test is a test that identifies patients who are high risk for plaque rupture. So an elevation that would predict a patient was high risk for myocardial infarction or a stroke. And most laboratories can run it. It's not well paid by insurance companies right now, but it's a great risk factor to measure. And there's not a lot of great ways to lower LPLA, but you can use statins, you can use niacin, sometimes the fibrates work, and omega-3 fatty acids work.
Okay, cool. Well, I'm going to go ahead and read the questions from now on. This question comes from Myrna, and she writes, how do you account for pathology-free metabolic syndrome in obese hibernators, e.g. bears? And then she references Science Volume 339, 2013. The negative effects of insulin resistance is less clear in the context of pregnancy and infection. Our current understanding of causality in human diet-induced obesity is incomplete. So,
well, that's a tough question. I think what I can say that I would know is that clearly visceral obesity is the main issue for insulin resistance, and the adipose tissue has well over 40 described adipokines that can cause disease. There's only a couple that are good, like adiponectin, but most of the others cause inflammation or oxidative stress or dyslipidemia or hypertension. And as you start to reduce those different adipokines, or you can balance them with higher amounts of the favorable ones like adiponectin, then the risk for all the cardiovascular events tends to decrease. And we do know that inflammation in and of itself does, in fact, increase insulin resistance in and of itself. So if you have an inflamed patient, no matter what it is, if you reduce the inflammation, then the insulin resistance gets better, and thus the dysglycemia improves.
Great, thank you. The next question comes from Kelly, and she writes, is the Genova Metsin test a good starting place for testing?
Yes, it's excellent. Genova, as you know, and Metametrics just combined forces, so most of the tests that you were getting separately now can be obtained through that one company. I'm not sure what their new name is, but it's Genova and Metametrics together now.
Great. And then this question comes from Zvi. He writes, at what age do you begin the intensive screening that you mentioned in asymptomatic patients?
Actually, I do adult medicine, but I'm getting a lot of younger patients now from their parents who have cardiovascular disease. So I'm starting to see kids as young as 13 years of age in my office, even though I'm not a pediatrician. And so it depends a little bit on the family history. But if you've got a family history in one or both parents, I would say that you do need to start screening maybe even before the teenage years, because you start developing atherosclerosis and fatty streaks literally right after you're born, if not in utero, in fact. So this is a very rampant disease that starts early on if you've got genetic tendency with environmental influences. And I will tell you, I'm seeing 13-year-olds right now who have hypertension, like 160 over 100. They have type 2 diabetes, and they have a horrible lipid profile, and they're overweight, and they're not exercising. 13 years old, and they've got, the risk, of a 40 or 50-year-old adult based on all the tests we're doing.
Right, thank you. This next question comes from Carrie, and it looks like it's a little overlap from one of the previous questions. But she writes, can you please explain LP-PLA2 and discuss what an optimal target level should be in regards to treating the endothelial inflammation?
Okay, yeah, it goes back to that other question, which is it's a predictor for MI and stroke because of plaque rupture. And we talked about the things that reduce it: omega-3s, statins, fibrates, and niacin. As far as an optimal level, it's going to depend on what lab you use. So I don't know that I can give you a specific number, but you would like it obviously to be in the normal range or as low as possible. But oftentimes it's very difficult to get it down, even with those treatments or combinations of those treatments, unless you can get to the root of the cause of it to be up to begin with, which may be one of the 400 plus risk factors we talked about. What you want to do, though, is try to stabilize the plaque and make it more stable, less prone to rupture. So those things I mentioned earlier that stabilize plaque and reduce plaque, like omega-3s, cowlick garlic, which is aged garlic, and vitamin K2, MK7, can stabilize the plaque and reduce the chance of rupture over time.
Right. This question comes from Julie. She writes, do you have an effective approach to lowering a very high calcium score of over 2,000?
Yes. I would use the three things I just mentioned. The aged garlic, omega-3s, and K2 and K7, definitely. I would add some B vitamins, probably some arginine with citrulline. I would use a compound called Neo 40, which is a beet juice extract with citrulline and hawthorn berry in it that raises nitric oxide levels very nicely. And I would probably, in this case, go ahead and use a statin and an ACE inhibitor or an ARB. Those are very helpful, and then either nattokinase or aspirin to reduce the thrombosis. And actually, we've got some clinical trials we've done using another compound. It's a fruit and vegetable extract. It's called Juice Plus, and we published that study, and we showed that we were able to slow down progression of coronary calcium score using a high intake of a concentrated fruit and vegetable extract over 1 year.
Oh. Well, this next question comes from Shabnam. I know he's one of our fellows, and he comes from India, and he writes, we have a very high incidence of CVD and HTN. I understand that the risk factors are different in Indians, particularly advanced markers. What is your opinion?
Well, I think that the markers really apply to any ethnicity. I don't know that there's that much difference. Biomarkers for CVD or biomarkers for CVD and ethnicity, different age groups and different genders. It's just that some populations may be more prone to developing an insult reaction injury depending on their genetics. So there's that genetic environmental influence. So, for example, we mentioned African Americans and blood pressure because of the non-dipping. There's obviously a lot of genetic variance, so that if you have a certain SNP and you have a certain environmental insult, you're more likely to develop cardiovascular disease from that. So I think what you're saying is true, is you may see variance in different populations to respond differently to environmental insults. But it's a matter of degree. It's not so much the fact there's really different biomarkers.
Great, thank you. All right, this next question comes from Galen, and he writes, how do you respond or react to a number of recent articles popular in the lay press about the lack of effect on cardiovascular morbidity or mortality of nutraceutical supplements, e.g. folate, vitamin E, fish oils, or free radicals?
Well, I typically read all of those articles because this is my area of interest and expertise, so I'm familiar with everything you've just said. So when I get those articles in there, it's sort of against the grain of what else has been said for the last 20 or 30 years, then I go to the methods section and read that first to see if it's even worthy of a good article. And typically, I will tell you, most of the studies that show a negative effect, for example, of omega-3 fatty acids or nutraceuticals in general, or, for example, treating homocysteine with B6B12 folic acid, are flawed studies. And they're flawed for very many reasons. Number one, they've used the wrong type of nutraceutical supplement, for example, for coronary heart disease protection. They might have used, for example, alpha tocopherol, which is the wrong kind of tocopherol, with selenium, beta-carotene, which is the wrong type of vitamin A, and vitamin C, but ignored all the other antioxidants. They picked four. What do we expect? Two of them were bad to begin with. They picked the wrong population. They didn't have enough patients in each group to even get a good statistical difference. They do meta-analysis, and they pick the studies they want in the meta-analysis, leave out the others. I mean, I could go on and on with all the different methodological flaws in these different trials. And I will say to you, one of the last ones that came out was omega-3 fatty acids, saying it didn't reduce cardiovascular disease. Well, there's hundreds of studies that show that they do. And this one was a meta-analysis using small doses of omega-3s. It was very poorly done, and it's not even worthy of consideration. I'm amazed it even got published. So I'm convinced, if you read the right literature and you read it with a good statistical significance, that there's a huge role for all the nutraceuticals, the vitamins, the antioxidants, the omega-3s for both prevention and treatment of cardiovascular disease.
Great, thank you. The next question comes from Ryan, and he writes, would you say there is no long-term role for pharmaceutical drugs in the treatment of heart disease?
No, I would not say that at all. There's obviously a role for pharmaceutical drugs in heart disease. You just have to know how to use them and when to use them, and you have to use an integrative approach. I mean, one of the things you want to be sure you learn as you go through any type of medical training is a wise healer uses what works. So, you don't want to be at the extremes of things, like I'm not going to use a drug, or I'm not going to use a nutraceutical ever, or I'm not going to even worry about nutrition. I mean, you've got to have a balance in your approach. And when you balance this, for example, if you know that statins have negative effects, and you know what they are, but you also know they have positive effects, you know which population to use them in and which one to use, you might use a low dose of a statin every other day or something like that, along with another type of drug that lowers risk for lipids. So in my practice, I typically use an integrative approach, which is scientifically proven nutraceuticals, nutrition, and drugs.
Great. This next question comes from Ben, and it's two parts. He writes, I thought studies show that omega-3 supplements are not effective in preventing cardiovascular disease, but eating fish does prevent it. And then he continues and he writes, as is so true, many supplements don't work, but the natural source does work.
Well, you make a good point, which is just because you take the main ingredient out of something and you condense it into a pill, that it's going to be better than the original product. So if I were to say to you, okay, your question is, should I eat fish or should I take omega-3 in a capsule, which would be better for me long term? I would say, well, if you can eat enough fish to get the appropriate dose of omega-3s in your diet without killing yourself with mercury, lead, arsenic, and other things that are in the fish, or it's really good fish and it's not farm raised or has other pollutants in it, that would be wonderful. But in this world, it's very hard to find cold water fish that meets those criteria, and it's very hard to eat that much fish to get that amount of DHA and EPA. So balance that again. I'd say you want to eat the best fish you can find, but also you're going to probably have to supplement with a high-grade omega-3 fatty acids to get to the dose you need required for the disease that you're treating.
The next question comes from Nelson Bennett, and he writes, his question is regarding to a device to measure endothelial flexibility. So he writes, I've seen a machine in a small computer-sized box that has a clip that goes on the end of a finger. Lying down with this on one finger for about 2 minutes gave a reading of endothelial health. Is that type of endothelial measurement device something you know about and would use?
Yeah, we mentioned that very briefly earlier, and there's two machines that measure endothelial dysfunction. The best one is Endopat, Endopat. It's made by an Israeli company, Itamar. We have that machine. We've been using it now for about 2 years, and it is very accurate for measuring endothelial dysfunction. This one has probes that go on the fingertips on both hands. So one hand's a control, and the other hand is your diagnostic test. And you occlude the brachial artery for about 5 minutes with a blood pressure cuff, and then you have a reflex hyperemia in that arm, and then you see what the difference is in blood flow on the two sides. And the Endopat is accurate, reproducible, and has clinical results that predict the risk for heart disease and stroke in the future, and it's published, correlates very highly with CVD, and it's much better predictor than the Framingham risk score, for example. So that's the Endopat. That's about a 10 or 15 minute test from beginning to end. The one I think you mentioned, which is a shorter test, 2 minutes, is called DTM, digital thermography, and that measures changes in the temperature of the fingers with a probe. It's pretty good, but the problem is if you don't have a warm room and you've got some sort of small vascular problem like Raynaud's, you can't really get an accurate reading. And the DTM does not have the clinical studies to validate it as well as Endopat. So if I were going to pick between the two, clearly at this point, Endopat is a better machine, more accurate than DTM.
Right, thank you. This next question comes from Julie, and she writes, is there a good non-invasive diagnostic test that uses no ionizing radiation to measure plaque load in coronary arteries?
Well, there's several you can do, but the problem is most of these require some sort of contrast to get the best study. Now, I'm going to tell you what's available. For example, the CT angio requires a lot of radiation, but it's a lot less than it used to be. The MRI, MRA also requires contrast dye to really get a good study. There are, research techniques using intravascular ultrasound, which are, obviously very accurate, but they're invasive, and it actually looks at plaque from the inside of the artery. And there's a lot of, non-invasive tests, but none of them really get to the root of what's the amount of obstructive disease that's in the artery. The one that I love the best, which unfortunately is not available much anymore, is electron beam tomography. It was the equivalent of about 10 x-rays, which was fairly low compared to CT angio, which is like 50 to 100 x-rays. The good news is most of the newer technologies are reducing the amount of radiation exposure. And we've got one that we use. We can do a calcium artery score with minimal radiation exposure, and the charge for it's only about $75 to $100 for the patient, and it gives you huge information on coronary calcium.
Right. This next question comes from Ben, and he writes, how do you feel about taking metformin in a non-diabetic patient to prevent cardiovascular disease and cancer?
I love metformin. There's great data with metformin. As you know, as an anti-aging medication, it works by blocking the TOR enzyme, or the TOR gene, which is an aging gene. It activates AMPK, which is another gene that slows down aging. It obviously improves insulin resistance, and there's a list of about 20 things that metformin will do, all of which are favorable related to cardiovascular disease, cancer reduction, stroke reduction, diabetes, dysglycemia, age products, and so forth. And so I would probably tell you it's off-label, obviously, but I think it's something that you want to consider. I would say probably 500 to 1,000 milligrams given at night or during the day, doesn't matter, you can split the dose, and just make sure the patients don't get hypoglycemic, which is not very common even with metformin in a patient who doesn't have diabetes. So probably a good thing to do, just be careful.
Next question comes from Kelly, and she writes, if we send patients, what is the cost range we can expect for complete testing? Is insurance coverage fair to good?
I'm assuming, I don't know, maybe we need to see if she's on the line. Are you asking me, are you sending patients, you mean to me for evaluation, or just sending patients for an evaluation in general?
Well, let me see if I can get her, see if she's there.
See if she's online there.
Kelly, are you available to talk?
Yes, for sending referrals to Dr. Houston.
Oh, okay. Yes. What we do, I have a person who's in charge of all of our consults for out of state or out of city people. His name is Chris, and what we generally do is have him contact you or the patient directly, and we set everything up beforehand. We try to do all the diagnostic testing within 2 days with a full consult. There's the fee that's charged for the consult, which is direct pay, and then there's the fee that's charged hopefully to the insurance. And it's hard to give you a number because it depends on the patient's history and their risk factors, their age, and so forth. But if you pin me down, I'd say probably in general you're looking at least $3,000 to $4,000 for the sort of the Ferrari workup to check everything in a good way.
Well, what would be the best way to get somebody in touch with you? I mean, you can always.
Let me give you a couple of contacts. The phone number for my office is area code 615-297-2700. I'll repeat it, 615-297-2700. That switchboard's often quite busy, so let me give you a couple of emails that you might want to use as well.
I'm writing these down on the slide here, so just so.
Yeah, okay. So what I'm going to do, I'm just going to look up real quick on my computer for you, and I'm going to give you the email actually for Chris Stokes, who's HCM. Okay, so here we go. You ready?
Yep.
It's hcm.members, MEMBERS, @gmail.com. So that's hcm.members@gmail.com. And that's to Chris, and he can contact you directly by email, which is probably the easiest way to handle most of your consults. And then you give him your number, and he can talk to you directly.
So that was only one H. HCM at hcm.members@gmail.com.
Right, and that's Chris is the contact. And I have a website too, which you can go on. It's hypertensioninstitute.com. Hypertensioninstitute.com, and that's got everything you'd want to see. It's got contact information, free information on protocols, articles, books. It's very complete. It was just updated about 3 weeks ago. It's got some videos on it, so you could literally spend a couple of days just on the website educating yourself about cardiovascular disease and hypertension and lipids, but also it's got all the information you need for contact. So it's hypertensioninstitute.com. Just plug that into Google and it'll take you right there.
Excellent, excellent. Looks like we have about 4 questions left. This one, 3 people, 4 questions. This one comes from Elizabeth, and she writes, what is preferred treatment of inflammation and elevated oxidative stress?
Great questions. For inflammation, if you're going to use a nutraceutical, I think the number one is curcumin. And I use very high doses, somewhere between 2 and 5 grams a day for really high C-reactive protein. You know, there's a whole list of natural anti-inflammatories that you can use, and there's obviously a lot of drugs you can use. I mean, nattokinase works, aspirin works, ACE inhibitors, ARBs, statins work. All those will reduce inflammation and oxidative stress. But if you look at natural compounds, I think the one that's got the best data is curcumin.
I have a personal question here. How does that compare to quercetin?
Quercetin is also excellent, and the use of those together actually can give you additive effects because they work through different mechanisms. One of them works through the LOX and the COX receptor, and the others work through NF-kappa B. So you kind of pick and choose 1 or 2 that are really good, give them in fairly high doses and in combinations, and you can really see the CRP drop dramatically. Obviously, eating a lot of vegetables helps. Getting away from high glycemic index foods helps. Losing weight, exercise, the usual list.
Excellent. This next question comes from Galen. This is 2 parts here. So Galen writes, I think that postmenopausal estrogen therapy in the appropriate setting, dose, and vehicle may be effective along with niacin in reducing LPA.
That is exactly correct. There's very good data that both estrogen and testosterone will reduce Lp(a). And as you point out, with niacin and N-acetylcysteine, that combination can be very effective.
Excellent. And then the second part of that second question from Galen is the ITMAR Endopat as clinically predictive as CIMT, or are they correlated to different clinical risks, either small vessel endothelial reaction versus large vessel myointimal hyperplasia?
Yeah, that's a very astute question. They're very different tests, actually. The Endopat is measuring only endothelial dysfunction, so it's a very early test, and ED occurs way before you start getting structural increases in IMT. So endothelial dysfunction by the Endopat with ITMAR would be one of the earliest predictors for CVD, and it's one of the first findings. Then the next stage is you start to develop intimal medial thickening, and that would be your carotid artery duplex, and which is really kind of a mixed structure function problem. And then the next step is you actually start to get arterial elasticity issues, hypertrophic changes in the artery, and plaque formation. So early on, Endopat, carotid IMT, and then later on you get the structural changes that are more irreversible.
So, it looks like I was about to give our last question, but it looks like we got a few more. Doctor, if you have time, Do you have time to answer more questions?
Yeah,
Or
we're good. Go ahead.
oh,
Sure,
great.
absolutely.
Okay, wonderful. Well, this next question comes from Kathy, and she writes, "What about the difference of nutraceutical fish oil and Loveza and bioavailability?"
Okay, I'm not a fan of Loveza, and I'll tell you the reason. It has only got DHA and EPA in there. It does not have a balanced protocol for reducing oxidative stress, and it also, given in large doses over time, can deplete another very important EFA, which is GLA. So I use primarily a balanced essential fatty acids from Biolix Research. It's called EFA Cert Supreme, and it has EPA and DHA at the appropriate ratio, which should be about 3 to 2. It also has GLA at the right dose because that can get depleted if you give just DHA and EPA. And even more important is it has gamma delta tocopherol, which is a form of vitamin E, which stabilizes all three of those in the capsule, but also when you take it, it stabilizes the DHA and EPA in your cell membrane, because you know polyunsaturated fats are the most likely to be oxidized in your cell membrane. So if you take a lot of these in high doses, you literally start oxidizing your cell membranes, and it can be detrimental to your health. So too much of a good thing is not good unless you have it balanced with the correct dose of antioxidants. And the primary antioxidant in your cell membrane is gamma delta tocopherol. So the EFA Cert Supreme, which is the one from Biolix Research, has all that in it in every capsule at the right proportion. So you just decide how much you want to give, and then you've got it covered. You don't have to worry about it. But I don't usually like to use Loveza or any EFA that doesn't have those four things in a balanced capsule.
Next question comes from Joy, and she writes, "What is the recommended doses of melatonin for improved cardiac function?"
Well, there's studies that are done in hypertension, and that's about the best data we have, and it doesn't take much. 2.5 to 3 milligrams of melatonin can not only lower blood pressure, but also convert patients from a non-dipping to a dipping pattern. You may have to use a little bit more in some people, but generally it doesn't take much. Obviously, a lot less than you use for insomnia. But there's also great studies with melatonin and a lot of other diseases which you're aware. So it's probably a good nutraceutical to use, definitely for hypertension, but also maybe in general for cardiovascular protection.
Great. Next, looks like we have two questions from Julie here. She writes, first question is, my understanding is that curcumin supplements can be difficult to digest. Is that true? Is there a special supplement that is well digested and absorbed?
Yeah, curcumin is as you point out, difficult to absorb, and it has to be given usually in high doses, and it has to be very highly bioavailable from a very reputable company. I think that the ones I would probably recommend to you that have really good bioavailability from Thorne, excellent curcumin, Douglas Labs, and Designs for Health. There are probably others, Metagenics, but all of those tend to be well absorbed. And there are some tricks about taking curcumin that may help the absorption, that related to what foods you're eating and other things that can increase absorption. But just be sure you get a really good high quality, and you can search them out. But I know those four labs typically have very high quality curcumins.
All right. This question comes from Ben. Ben writes, "What would be your formula for a natural approach to treating hypertension? I love magnesium. What are your thoughts?"
Well, Ben, I would refer you to my book on what your doctor does not tell you about high blood pressure, which you can order on Amazon, which has everything you'd ever want to know about hypertension. Also, there's about 6 articles that I've written, which you can pull off of PubMed. If you just put in my last name, Houston, MC, and hypertension natural treatment on PubMed, it'll pull up all those articles, and you can download them. And you can go to my website, hypertensioninstitute.com, and also find out we've got protocols, plus we have articles you can actually pull off the internet, off the website. But in essence, magnesium, as you point out, is a very good one. Lycopene, whey protein, coenzyme Q10, I mean, the list is fairly huge. There's probably about, I would say, 15 or 20 supplements that are really well documented in the literature, and you can use them in different combinations to get blood pressure controlled. In fact, one of the studies that is, we'll pull it up when you pull it up on the internet, we published a trial where we took hypertensive patients who were on drugs, and we gave them nutraceuticals, and obviously we had them eat good, lose weight, and exercise. And within a year, 62% of the patients who were on blood pressure medicines were able to discontinue the medicines and were controlled at 120/80 or less just with that nutraceutical program.
Wow. Could you repeat the name of your book one more time?
Yeah, it's What Your Doctor May Not Tell You About Hypertension.
Great.
It's available on Amazon or most bookstores.
Oh, we have a question here from Robert, and he writes, I had a patient on curcumin, and the nephrologist had him stop it because of some data questioning its use in a patient with chronic renal disease.
I haven't seen the data. I would love to see the study. That's what you always want to ask people when they pull people off things you think are good for them, to document that what they say is true, to be sure it's not some animal study or some in vitro study. But I will tell you this, I have not seen anything in any good studies that says anything detrimental about high quality curcumin. Everything I've seen actually shows that it reduces inflammation, cardiovascular disease, improves brain function, improves blood pressure, reduces stent restenosis, bypass graft, proteinuria, and may actually improve renal function. So that's at odds with everything that I've actually seen. I've also seen good data that says omega-3 fatty acids improve renal function and reduce proteinuria. So in my patients, and I've seen this consistently, if I have renal dysfunction, I usually put them on a combination of omega-3s, curcumin, N-acetylcysteine, and CoQ10, and they often have stabilization rates, improvement in their renal function, particularly if you use it in conjunction with RAS drugs like ACE inhibitors and ARBs.
Okay. Next question is from Linda, and she writes, what is the best way to get no high in the body? If you need me to unmute Linda to elaborate.
Say that again. Say it again, Dan.
What is the best way to get NO high in the body? I guess nitric oxide.
Nitric oxide. Okay.
Right, cool. Yeah.
Okay, I got you. Yeah, nitric oxide is obviously the one of the most beneficial gases released by the endothelium to reduce cardiovascular disease, and everything you want to happen is good occurs with nitric oxide. So here's the main point. Nitric oxide comes from two major sources in your body. It comes from arginine, which is produced through an enzyme called eNOS, and goes through a lot of different pathways, but that eventually ends up as nitric oxide. The other way you get it is through your food, through nitrates and nitrites. And you have bacteria that are on your tongue and your GI tract that actually break down these compounds, and eventually the nitrates will form nitric oxide. So you have to look at foods that are very high in nitrates and nitrites. Well, one of the highest ones is beetroot. Okay, so but you can get it in other vegetables, but beetroot is very high, and that is the compound we're actually doing a study on. It's called NEO40, NEO/40. It's developed by a PhD in Texas from a company called Neogenis. It's a wafer. You put it on your tongue. It dissolves in about 2 minutes, and you get almost immediate improvements in nitric oxide, endothelial dysfunction, and it actually can lower blood pressure. So we use that to give you the nitrate part, and we use up to 5 grams of arginine per day, sometimes up to 10 grams depending on the situation. And you kind of hit it from both ends, and use a little citrulline with it. That helps. So those are the main things. There's a lot of things you can use too, like tetrahydrobiopterin and folic acid and all the B vitamins, things that kind of increase enzymatic activity and increase the production, but also reduce the breakdown of nitric oxide. So real simply, though, just to get started, get you some NEO40 and some arginine, and that's a good way to start getting NO up.
All right, this next question is from Robert, and he writes, if blood pressure returns to 120/80, I never stop the ACE1 because of supposed intravascular benefit. What do you think?
Yeah, clearly ACE inhibitors and ARBs have an independent effect on vascular health that has nothing to do with their blood pressure. And they're actually used to promote, to slow down vascular aging. They increase arterial elasticity, improve endothelial dysfunction, increase nitric oxide, reduce inflammation, oxidative stress, everything gets better. So I would recommend, and I do this all the time, I tell people, look, your blood pressure is good, but, there's a lot of other benefits with this ACE and ARB, so you might want to keep taking it just for that reason if you don't have any objections and not have any side effects, and it's very effective.
All right, well, I think this is our last question here, and this one comes from Robert, and he writes, is there a valid test to measure nitric oxide?
There's no way to actually measure NO because it's a gas and it has a very short half-life and it's gone. There are urinary metabolites that you can measure, but they're interfered with by so many substances that it's not accurate. The only way that you can really get at nitric oxide, and it's sort of indirectly, is by measuring ADMA, asymmetric dimethylarginine. So asymmetric dimethylarginine, or ADMA, if it's elevated, tells you probably that your NO levels are actually low. Now, the test that is available through this study we're doing with Neo40, there's actually a sort of a tongue measurement you can do. You put it on your tongue, and it will sort of give you an idea of what the nitrates are on your tongue. Now, that's not a direct measure of NO. It just tells you that you're not making enough nitrates, therefore your bacteria on your tongue are not doing their job, and you need to increase your nitrate intake. It's an indirect measure of NO, but it doesn't really measure NO directly. So if I were going to tell you things you could do in the laboratory, get ADMA. There's a lot of labs that do that, and then you get that's Neo40, and you can get these test strips that you put on your tongue, and it gives you an indirect measure of nitrates. Those two will give you a pretty good idea of nitric oxide availability.
Excellent. Well, I appreciate. Oh, it looks like we just got one more question pop up here from Nancy, and she goes, "Where can you get a HRV machine?"
Heart rate variability. There's several companies that make it. I think probably the best one is HeartSmart.
Great. Well, perfect.
Or HeartMath, I guess it is. Yeah, HeartMath. Excuse me.
Okay. Wonderful. Well, that concludes our webinar tonight, and I want to thank Dr. Houston for doing this with us and answering all these wonderful questions. Dr. Houston, thank you. And
my pleasure. Thank you all for attending, and I look forward to seeing some of you at Module 16.
Excellent. And Doctor, what was the name of your book again?
There's two books out, Daniel. They're both on Amazon. The first one is What Your Doctor May Not Tell You About Hypertension. That one is complete with all the things about how to treat blood pressure naturally. And the second one is What Your Doctor May Not Tell You About Heart Disease. That one just came off the press this last year, and it has a lot of the concepts we talked about tonight of how to effectively treat and diagnose heart disease.
Awesome. Well, just so you know, folks, again, this is the tip of the iceberg for Module 16, which is a complete Metabolic Cardiovascular Medicine certification program through the American Academy of Anti-Aging Medicine. And if you have any questions about this program or anything else, please give us a call at 561-997-0112. You can visit a4m.com. or you can email us at info@a4m.com. If you have questions for Dr. Houston's office, for any referrals, please call 615-297-2700. You can email hcm.members@gmail.com, or you can visit Dr. Houston's website at hypertensioninstitute.com. Again, Dr. Houston, I appreciate your time. Thank you, and thank you for everybody for logging in tonight. Again,
thank you, Dan. Thank you all for attending. Have a good night.
Thank you, everybody. Have a good one.